Hey everyone, welcome to my Day in the Life series here on White Coats and Corgis. Most of you probably know me from Instagram or TikTok, where I make helpful free content for premeds and talk about my journey as a first-generation medical student. My mission here on YouTube is to give pre-med students all the information they need for a career in medicine. So in order to do that, I've teamed up with MedSchoolCoach to create this series where I'm going to do a deep dive on each medical specialty. And I want to start off by saying that it can be really difficult to accumulate the number of shadowing hours you really need to be accepted into medical school. And especially nowadays, this can be really challenging. A lot of physicians aren't open to shadowing opportunities in person the way that they were before. So that is why MedSchoolCoach decided to collaborate with over 20 doctors to give you a behind-the-scenes look at practically every specialty that you might be interested in. And this is all completely free. You can go to shadowing.medschoolcoach.com, register for the program, and then you get to choose whichever specialties you're interested in to shadow. At the end, you can fill out a short quiz, and then they'll give you a certificate of completion. That way you can count these hours on your medical school application.
I think this is the best way to describe interventional radiology, right? It's like surgery, only magic. It really is. Like, the things that we're able to do are very much like surgeries, right? They're minimally invasive surgeries. In fact, there's an entire group of interventional radiology that probably calls ourselves more minimally invasive surgeons than radiologists. Now, interventional radiology is typically considered a subspecialty of diagnostic radiology, although a couple of years ago, actually, interventional radiology started having its own residency. So now if you're a med student, you can actually go right into interventional radiology. It's still certified by the same board, but basically it's something where we as interventional radiologists do not necessarily do the same. We don't actually do anything like a diagnostic radiologist does on maybe an everyday basis. So it's kind of a different field, and I would consider it more of a surgical subspecialty than a subspecialty of diagnostic radiology. At least that's the way I sort of look at it. And what makes IR awesome? I think what makes IR awesome is really we have this attitude of we can do it, right? I think interventional radiologists are often the last line of defense. And what I mean by this is there's so often on an everyday basis, it's like, well, this patient is too sick for us to take to the OR. Or, hey, we couldn't get that central line in. Can you help us out? Or, this patient basically is going to die. What can you do? Like, these are everyday conversations. And as interventional radiologists, we're often the last line of defense in the hospital. And it's like, well, yeah, let's try something. We can do it. And the reason that we can often do something is that interventional radiologists definitely think outside the box, and I think are the ultimate problem solvers. And that's kind of, I talked about it as an engineer, sort of thinking through, hey, what at the end of the day is sort of applied science, and what problems can I solve in front of me? Like, interventional radiologists are really a good interventional radiologist can think through these problems and think outside the box and really come up with incredibly unique solutions to different issues. I mean, we have a procedural skill set that's really unmatched by any specialty. So there are other specialties that will do some of the stuff we do and have endovascular skills, for example, cardiology, neurosurgery, vascular surgery, all do things that are endovascular related, right? Catheter and wire skills. But the skill set of the interventional radiologist is that, plus so much else from a procedural standpoint. Now, I can't crack open a chest and, tie a thoracic aortic graft like a vascular surgeon can, of course, but I can think about ways to treat this through maybe an ultrasound procedure combined with a CT, and being able to get to the smallest arteries in the body with a catheter and essentially put a coil there or something along those lines, right? So the procedural skill set that we have as interventional radiologists, I think, is really unmatched by any other specialty. And then I think what's so cool about IR is literally I take care of patients across the spectrum. And that really means like pediatric patients. That means patients who are dying on the table. Like, literally, this patient is going to die on the table pretty much every month. Unfortunately, we have a patient who dies on the table because they were so sick and they needed an IR procedure, and they unfortunately didn't make it. At the same time, I treat patients who say, you know what, the vein in my leg is bothering me when I wear a swimsuit. can you help me with that? So we do like cosmetic procedures, right? So this like entire spectrum of procedures that an interventional radiologist can do, and the types of patients we take care of is just so varied. And that's one thing that's really cool to me about it. It's there are other specialties that are very focused, right? And that's awesome, because they're super focused on just that and that problem over and over again. In IR, we're focused on problems of the vascular system. We're focused on problems of the brain. We're focused on problems of the GI system. We're focused, like, it's just all over the spectrum of what we can do. Again, from the sickest patient who's dying on the table to literally that patient who says, again, like these varicose veins in my legs are kind of unsightly. Those like spider veins that you get, the veins in your legs that kind of look funky, and you wear a swimsuit and you don't like them, like we treat those, right? That's some of the stuff that we also treat. So it's like this wide spectrum of things that we treat that I think makes it super exciting. The type of patient I treat a lot is through a pretty rare procedure called a prostate artery embolization, where patients who have benign prostatic hypertrophy, right? So this is basically their prostate gland has swelled in size. BPH, right? This is something that happens in really all men. Unfortunately, as we get older, your prostate gets bigger. As your prostate gets bigger, the prostate sits between the bladder and the urethra, or the urethra actually courses through the prostate. It sits between the bladder and the penis. And the urethra, which takes the urine from the bladder out the penis, ends up getting squished essentially by a big prostate. And when that gets squished, you end up getting a lot of symptoms, like you get up very often at night, you go very often. So it's a really common problem, often treated by urologists, but I can treat this with something that's called a prostate artery embolization. So that's me at an academic center having a pretty very subselective small procedure that I do very, very often. There's probably only 2 or 3 other people in the country that are doing as many as I am on that. But that, for an IR in general, they are treating literally, across the spectrum of things. And I'm also treating across the spectrum of things. So it's really, there's not like one procedure that any IR, you can go to 3 different IRs and they'll tell you they do 3 different procedures the most in any given day, right? Or really 30 different IRs, and they might tell you 30 different things that they do. So it's really varied in that way. And so we've been talking about these procedures, and I put some of these pictures in because this is literally what it looks like. Like, these are my hands on an everyday basis, right? Like, this is what I'm doing all the stuff that I just talked about and will talk about through. Like, I'm literally doing it through these little wires and catheters outside the body. And it's, that's why I think it's really magical at the end of the day. Like, this is all I'm doing, manipulating wires, manipulating catheters outside the body. And with that, being able to solve all these problems. And so you can see, we get a little bloody, but we're not cutting people open. We definitely have blood on the table. Blood comes out of the arteries and those kind of things. But it's we're not doing big open surgery. Instead, we're being able to do it literally through these wires and catheters at the end of the table. And that's all it is. Like, this is all that's inside the patient. I'll even show you a picture. Here you go. This is what's called a sheath. This is an instrument that basically is a big IV. It's a slightly bigger IV. It's not a huge IV. It's like, you can kind of see the size of it. It's not that big, but this is literally what I do all my procedures through. This little thing called a sheath is what I can do all my procedures through. And you can imagine at the end, you just put a Band-Aid on top of the patient and they're sort of done, right? This is what it looks like. So you're working with your hands on a second by second basis. That's what you're manipulating. You're manipulating these wires and catheters. So that is, when you say it's a specialty that works with your hands, this is what it means, right? You're really a specialty that works with your hands in that way. And the skills you need to sort of like develop a wire feel and understand where to navigate these things through all come based on like tactile feedback from these wires, and how it feels inside the body at any given time. This is what a room looks like, right? So this is my operating room. This is what I walk into. And so you can see it's pretty futuristic in some ways, right? This is where the patient would lie, right? This is anesthesia stuff. Sometimes we do this with these procedures with anesthesia, but a lot of times actually we do it completely without anesthesia, which is the other incredible part of all this. We can do all these procedures with literally only local numbing medicine or some sedation medicine. And then you see all these big screens, which is kind of where I'm looking and understanding what's going on at any given time. this is kind of what it looks like, right? So this is us sitting there. We are manipulating these little wires at the end of the table. And what we see on the screen is basically fluoroscopic images or X-ray images, sometimes CT, maybe ultrasound images of what's going on inside the body, right? So I'm actually watching my wires and catheters go through the body. I'm watching them sort of take turns. This is an aortogram. And basically you can see that these are the vessels that would be supplying your leg. And you can see like on this side, this person has pretty good flow, but where is it on this side, right? It's completely gone basically. And this is somebody who, for instance, would basically be presenting with leg pain because they have severe arterial disease, right? Their arteries are clogged up. Your arteries get clogged up with calcium. They get clogged up if you're a smoker. And one of the things we can do is open these back up. So we would actually go through and get back and then be able to stent these areas open and increase the blood flow to the legs. So that's something that's very, very commonly done, right? And we're doing all this through like this tiny little pinpoint hole. But this is sort of what we look like on an everyday basis. Like this is where we're gowned up, we're garbed, we're wearing lead underneath to protect ourselves from the X-rays. This is the X-ray machine that's using. Actually, in here you can even see a CT machine in the back. So sometimes they have a CT and X-ray sort of combined, or an MRI and a X-ray combined, and it's super futuristic in that way, right? I mean, this is like you're literally peering inside the body as you're doing this without cutting anybody open. Like it's pretty wild. I mean, I will go through a bunch of stuff here, right? And basically on any given day, I get in around 7 or 8 o'clock, and I go through inpatient rounding, right? So I see patients who are in the hospital who perform procedures on, or who maybe we've consulted on, right? Maybe there's a medicine doc who said, hey, can you take a look at this patient because they had a GI bleed last night? I want to see if you can do anything. And I tried to kind of put on the spectrum of patients, right? It could be a young, healthy patient who came in with trauma, right? They got their car accident and they had a splenic laceration, right? So their spleen was bleeding and we needed to do something. IR can do something about that. Or maybe an OB patient who just gave birth and they can't stop the bleeding after the birth, right? The placenta, basically the uterus isn't contracting in the way it should, and so the patient is still bleeding, and so we can help that person by doing an embolization. They're patients with cancer, right? Maybe they just need something as simple as venous access, or maybe they have a blocked bile system and the GI docs couldn't get to it or couldn't access the anatomy. Maybe they have a liver cancer, which we can do something called an ablation or an embolization on. They may be liver transplant patients, right? They just got into this big transplant and unfortunately their artery went down, right? So there's an artery that connects the transplant surgeon got out of the OR and said, oh man, there's like no more flow in this artery. I need you to open this back up. So you can see like just a wide spectrum of patients that we can sort of work on a daily basis. And literally these are patients who would be on our, what we call our list or what we round on a daily basis. And so I'm seeing patients, I'm interacting with patients, I'm interacting with the referring physicians. Then we'll typically start our procedure day, and it could be, a bunch of outpatient procedures, right? A uterine fibroid embolization, a transarterial chemoembolization. So this is treating a patient maybe with fibroids, a young healthy woman with fibroids. This is treating somebody with cancer. I talked a little bit about the prostate artery embolization, which is something I do a lot of, treating an older man with urinary symptoms, peripheral artery disease stenting. Like it just goes on and on and on. Some of the stuff that we do, and again, it's so varied on a day-to-day basis. There could be biopsies thrown in here or drainages, right? So biopsy is when a patient maybe has a tumor or something that they see on a CT scan, but we don't know what it is, right? And so we're not going to cut them open and take that out before we know what that is. We need some tissue for our pathology colleagues to sort of look at it under a microscope and say, okay, what is this? This really is cancer, or this is not cancer. Maybe it's something benign. And so we're able to get to those areas and actually biopsy them without cutting the patient open, right? We're just able to put a small needle in, take a small sample, send it off to our pathology colleagues, and then they look at it and say, okay, yeah, this is X or Y, and then we treat them accordingly. We'll typically do a couple of outpatient procedures in a day, and then a lot of IR is actually based around inpatient procedures. And so people in the hospital who are super sick or come in, right? trauma cases, people who are bleeding out, people who have infections or clots. And the clot could be in the brain, it could be in the arms, it could be the legs, it could be in the lungs, aneurysms. Like these are all things that we sort of work on. And then in between, I'm seeing patients on the floor. I'm discussing, their conditions with referring teams. And then in my practice, 1 day a week, I basically have clinic time where I'm actually doing no procedures. I'm actually just seeing patients, right? And these patients 100% consider me their doctor. And I think that's a important sort of consideration, right? There are specialties where you are a subspecialist or somebody behind the scenes, right? Where maybe you're not necessarily considered that person's doctor, although you have incredibly important role in that person's care, right? Like say a diagnostic radiologist or a pathologist, right? They're sort of behind the scenes and helping other doctors understand what's going on with their patients. But an interventional radiologist, I'm actually that patient's doctor, right? I'm seeing that patient, I'm talking to that patient 100% considers me their doctor, which again, I think that's sort of why I really like IR, because I get this whole spectrum of things, right? I get clinic time, I get procedural time, I get super sick patients, I get well patients, I get really the entire spectrum of things. And so, what I wanted to do was take you guys through just a couple of cases, right? To think through like what this looks like. I'm going to create some new pathways. I'm going to fix an aneurysm. I'm going to stent a venous obstruction. I'm going to open up veins that have been clotted for years and restore intractable pain, right? So these are 5 different cases that I thought just capture, sort of an everyday life in interventional radiologist. And I can go on, I could have 50 cases that are interesting like this. This is just a small version, but here's the first case. And so as a physician, as a med student, these are some of the things where you see coughing up blood. It can actually be caused by a huge amount of different things, right? And the goal of a clinician is to actually nail down what's causing that. And so I, as an interventional radiologist, may actually not be involved in the nailing down of that. Actually, that's more of maybe the emergency medicine doc or the internal medicine doc who's taking the initial history of things. But they may call me later when they say, okay, you know what, this is due to varices. And so just want to take you guys through why this may happen, right? And so let's say that this guy said, you know what, I'm drinking 10 pints a day, 10 beers a day for the last 30 years, right? You're kind of really thinking that this guy has liver problems at the end of the day. And liver problems and coughing up blood very much means that this person has varices. The body has this incredible way of adapting to different situations. And varices is an adaptation to a bad situation, right? So this is your liver, right? And the whole point of your liver is to filter out blood, right? So anything you eat basically goes through what's called your mesenteric system, and the nutrients and everything else, nutrients and good stuff and bad stuff essentially come back through the mesenteric system, right? This is kind of an oversimplification, but I'm going to go with it anyway. Basically, the blood, when you eat something, needs to be filtered before it goes back to the rest of your body, right? So if you've eaten toxins, if you've eaten something that the body doesn't like the liver is your filter at the end of the day for those things, okay? And so what happens in a normal situation is your blood, the nutrients that the blood needs will come back. These little red dots are blood. It's going to come back. It's going to be filtered by the liver, and then it's going to go up the hepatic veins. And actually your heart would sit up here. And it goes into your heart, and then your heart pumps, and then it gets it to the rest of the body, right? Actually goes to the lungs and then gets to the rest of the body. So that's basically what happens to, that's what your liver does. It filters out toxins at the end of the day, right? And simplification is your liver filters out toxins. What happens when you drink a lot is that your liver ends up being crappy, right? It ends up sort of not working the way it should. And so instead of filtering out, it basically becomes hard. And as it becomes really hard, what happens is that blood can no longer flow through the liver in the way that it's supposed to. And so instead, what happens is that blood goes up, and it actually, like, the liver kicks it back out. It's like too high resistance for it to go through the liver. And so what it does, it actually goes through veins that are really not supposed to be there, or were there when you were a baby. There's this whole other talk probably on OBGYN about this incredible, what's incredible about like the fetal circulation it's really cool. Basically, the fetal circulation is sort of almost reversed compared to the adult or even pediatric circulation. So when you have a placenta, things go opposite directions. And I'm not an OB, and I'm not going to talk about that because I don't remember any of that. But basically, there are all these different pathways that open up, and one of them is like the coronary vein, and this is the stomach. These are what's called short gastric veins, and basically um, they will kind of go around the stomach or the esophagus. And so in a normal situation, you don't have all these veins, and they're not very big. But in an abnormal situation, when your liver can't filter out the blood, essentially these get really big. Okay. And so what happens is that these get really big. They sort of hop around and go around the esophagus and stomach. And these are what ends up bleeding, right? And that's what's called a varix. A varix is basically an abnormal vein, something that is dilated to a area where it shouldn't be and can easily cause bleeding, right? The blood's got to come back somehow, right? And it comes back through these different pathways. And so there's a lot of things that people can offer this patient, right? So the medicine ED team, they can fluid resuscitate the patient, right? Let's say that they're dying on the table, their blood pressure is low. Maybe they placed that central line we talked about, right? And they gave them a bunch of blood real quick to get their blood pressure back up. They can start drugs to pressure support and constrict the system to make sure that essentially the brain gets enough blood so that the person doesn't die of brain damage in the meantime. Our GI colleagues can do a lot of stuff with these varices, right? They can actually go in through the mouth and they can band a varix. So they can see a bleeding varix and they can band it. They can place what's called a Blakemore tube, which is essentially like a really big balloon to stop the bleeding at that juncture. And then there's also some surgical options, but the surgical options aren't really very good in the short term, right? So if this person's like coughing up blood, you can't go get them a new liver and place it into their body right away. Liver transplants take years to get, so this patient may end up being referred to IR. And what I think is really cool is what I'm going to do for this patient is I'm going to create a new pathway, right? So here's how I'll talk to the patient. I'm going to save your life by having your blood bypass these bleeding veins, by creating a new pathway for the blood to flow through, by blindly sticking a really long needle from one side of your body to the other, and then putting a stent through the liver. And at the end, I'll put a Band-Aid on your neck. Like, that is what I'm going to do for this patient. And I say this because I think that this is like the coolest thing in the world, right? So this is what's called a TIPS procedure. And actually, this is one of the ways I initially got interested in IR. I remember hearing about this in med school and I was blown away. I was like, wait. What just happened there? We were able to save this patient's life who was bleeding from a varix and create this whole new pathway through the body. And then put a Band-Aid on their neck at the end and they walk away. Like, that blew me away. And so this is what's called a TIPS procedure. And essentially, this is the liver again. What we do is we come down through the neck and I find the hepatic vein, which is the vein that essentially drains the liver. And I essentially get into here and then I stick with this really long needle from the neck and I try to find the portal vein, which is that vein that brings the blood back from the bowel. And once I'm able to stick there, I'm able to place a stent through essentially at the end of it. And that stent now, instead of blood coming here and then getting to the liver and then flowing back like we saw in the bad liver, what it's able to do is able to go through here and then go through the stent because that stent is just open and a path of least resistance. And so blood can kind of flow back the normal way it's supposed to flow. I mean, basically what we do is while we're doing this, we understand where the hepatic vein is. Based on anatomy and based on doing this a lot, you know exactly where these things are supposed to be. You inject some contrast essentially as you go to be able to find your way. But I can tell you, right from an x-ray where I'm at. So I look at the x-ray and I look at where my catheter is and I know exactly based on anatomy where that hepatic vein is supposed to come off. And I know it's okay, it's right there. Now, for the portal vein, oftentimes we are sticking blindly in some ways, but we know, again, based on anatomy, maybe based on the CT scan beforehand, well, it's in front of where my catheter currently is. And so I'm going to angle this needle essentially forward. And as I angle this needle forward, it should hit that. Like, that's kind of how we do it. We kind of know the anatomical relations of things and are able to find our way based on that. This is kind of what it looks like. So, if you were sitting there next to me, like this is what I'm looking at, right? I'm like literally staring at the screen, and this is kind of what it looks like. So I've come down. This is the heart right here. This is the liver. And we just kind of know that from looking at x-rays and understanding. And I know that this is the hepatic vein. And so this is after that tip stent has been placed. You actually see, I mean, you see that like a little ring and all these stents. That's the tip stent. That's the stent that we've placed. And what you see is that as we inject here, these are the varices. Remember I said that blood should normally flow this way and then up this way. But what you're seeing is that blood is actually flowing this way and then up this way because that liver is really hard. And so this right here is kind of where the stomach lies. And you can imagine if you have this giant vein wrapping around the stomach or around the esophagus, that's what causes it to bleed. And so in this case, we placed the tip stent, which shoves the blood the way it should. And then we actually ended up coiling this thing and embolizing it. So embolizing means shutting down the blood flow. And we basically pack this thing with a bunch of metal coils and plugs. And then as we inject, okay, now we see blood is no longer flowing all the way up here. It's flowing back this way in the way that it should. And so this patient is no longer going to bleed from that area. In fact, the blood's going to flow back the way that it normally should. So that's a TIPS procedure. It's called a TIPS, and again, it's like one of the coolest things I think that we do. And again, I was blown away about this in med school, and now I, do this twice a week. It's one of these things where I was like, wow, this is super cool. And these are the things that we kind of do every day as IRs. So, here's another, case. So 76-year-old male came in with hypotension, right? Hypotension means your blood pressure is low, right? And so when your blood pressure is low, you got to be thinking about a number of things. Obviously, there's a lot of reasons for hypotension, but one of them could be bleeding. And in this case, what you're actually seeing is a bleeding blood vessel. So this is what's called a CT scan, right? A CT scan is a way to peer inside the body. And a diagnostic radiologist really reads these CT scans and is able to understand them. As interventional radiologists, we are trained in diagnostic radiology, so we can read them and understand them too. Emergency medicine people can, surgeons can. Like a lot of people are going to be able to read a CT scan and kind of get a gist of what's going on. And what you see here is this is the aorta, right? This is like the big vessel that's taking blood from your heart to your legs, and then you see this giant thing here. That's totally abnormal. That shouldn't be there in any way whatsoever. You can see it also on a coronal plane. So this is sort of cutting. This first picture is cutting you this way and taking a look. This next picture is cutting you this way and taking a look. And so what you're seeing here is this giant aneurysm that is losing blood, right? So this person is losing blood from this aneurysm. Aneurysms can happen all over the place, in the arteries, it can happen in the veins, but it can happen in the aorta, it can happen in the thoracic aorta, like up here, it can happen in the abdominal aorta, or it can happen in these small vessels. In this case, the aneurysm is actually off of what's called the common hepatic artery. And so this is us, right? So this is what I'm seeing. As I'm doing this, what I've done is I've gone in through the groin, okay? I put that tiny little needle into the groin with that little IV, and I've inserted this long catheter, and I found my way up to what's called the celiac artery. And then I've injected the celiac artery, and I see normal artery. Okay, that is very abnormal. Arteries should get smaller as they go, right? So if you kind of don't look at this for a sec, look at this, right? So this is a normal artery, and it's like a tree, right? The branches of a tree get smaller as you go. So it gets smaller and smaller, right? Smaller and smaller. The ones in the middle are bigger, and the ones out in the periphery are smaller. This is clearly not supposed to be there. That entire thing is not supposed to be there. This is a giant aneurysm that's bleeding and is rupturing and causing the guy to continue to bleed and die and lose volume, right? And so how do we solve this problem? Well, what's, again, so cool about IR is we can actually solve this problem by, what I've done is I've put a sheath up here, and I'm about to put a stent right over that area, right? And so as I put that stent over the area, what's going to happen is that the blood is just going to go through there. It's a covered stent. So I've deployed a stent across that entire area. And now I inject again, and you don't see the aneurysm, right? Because I've totally excluded it. I've totally taken it away, because the blood can no longer fill that aneurysm, which is essentially a hole in the artery, right? So here we had a giant hole in the artery, and then I essentially plugged the hole, right? I did some plumbing, right? I patched the hole with the stent, and that's it. This is what's called a CT scan after, and you can see that that big aneurysm is gone. You can see this flow maintained all the way to the liver, right? So you couldn't just go in and operate on this. If you went and operate this patient would die, right? So if you tried to cut this patient open, like, what are you going to do with this thing? It's going to burst open. It's going to bleed everywhere. This is the only option this patient had, was to be able to somehow embolize, stent, graft, or whatever else, shut that down through an interventional approach. And so this patient had a surgery in the area of the liver previous to this, and that's what caused this this artery to open up. So there was some manipulation during surgery that unfortunately caused the artery to have an issue.
Wow. Cool.
Got it. So, here's just sort of some of the ways we treat aneurysms, right? So this is basically the way I treated that aneurysm, right? I basically put this stent graft in. But we can do other things too, like we can coil the aneurysm. We can pack a bunch of coils in there to thrombose the thing off. Or we can maybe even coil basically the inflow and the outflow to an aneurysm. So there's blood that goes in, there's blood that comes out. What if I just shut down that entire artery and say, no more blood here? Like, let's just stop blood going here. You want to do different things in different cases, right? So in this particular case, I couldn't do that because the rest of the blood was actually supplying the liver. And so you can't just stop the blood that's supplying the liver. That would cause issues. So I needed to keep the rest of the blood open, and in which case a stent graft is a really nice option. Keeps the rest of the blood sort of flowing. All right, so here's another case. I'll go through the last ones a little bit quicker, just so you guys sort of get a feel. So, this is a guy who's coming in with facial swelling and shortness of breath, right? And a couple of things, for pre-meds to notice. He's got a tube down his throat, right? This is a endotracheal tube. So he's being ventilated at this point, right? So he is basically being ventilated, supportive oxygen and supportive respiratory systems, right? So he's hooked up to a big ventilator, which is pumping air into his body. You can see that his face looks pretty swollen, right? His eyes look pretty swollen. He basically, his neck looks big, and he's coming in with this shortness of breath and facial swelling, and had to be intubated because he just essentially couldn't breathe. And this is sort of classic for something that's called SVC syndrome, or superior vena cava syndrome, right? And so you look at this picture, I mean, this is obviously a graphic, but that's kind of exactly what he looks like, right? Like, his face is all swollen. And the reason for this is oftentimes that there could be a lung tumor or something along those lines blocking the blood flow from the face back to the heart, right? So blood's got to come back somehow, right? Blood's got to come back from the brain back to the heart to be pumped to the rest of the body. Blood's got to come back from the arms to the brain, to the lungs to be pumped to the rest of the body, right? If you had something that's blocking that blood vessel, basically blood backs up. And so in this case, what happens is that there's a tumor blocking, which often can happen, the main blood vessel called the superior vena cava, that takes all the blood from the head and brings it back to the heart. And when it blocks, basically that blood backs up. And so what you see is this guy's face getting swollen because blood is essentially backing up, right? It has nowhere to go. At the end of the day, it's all plumbing, right? So it's all just basic plumbing. Blood is nowhere to go. It backs up to his face, and that causes his throat to swell. That causes his eyes to get puffy. That causes his head to get big. That's superior vena cava syndrome. And so this is kind of what a CT scan looks like of that. You can see these are sort of normal lungs. And then you see this gray area here, right? Like that's abnormal lung, basically because he has a big tumor here. And this is the same CT scan, just essentially filtered, right? So this is kind of like an Instagram filter, but an opposite, right? So this is a way for us to see. You can see here, I can see the lungs real well. Here, I don't see the lungs at all, but I see the blood vessels real well. And I can see that there's a clear narrowing of the superior vena cava, right? So this is the blood vessel that should be coming down here. And there's a clear narrowing because of all of this soft tissue there. And so what I would do as an interventional radiologist, I do a venogram, right? And so I come in, and in this case, I actually come in from the groin, and I do this injection. So forget the right side for a second. Look at the left side, right? When I do this injection, what you see is all these blood vessels that shouldn't be there, right? They're going up to the face essentially. And so essentially what you're having is a backup of blood through the system, right? They're going back up the system. So instead of blood going from here down here, it's actually going from here up here, right? And so that's what's causing the backup. And so what I did here was place a stent. The minute I place a stent and inject that contrast again, you see all of these things are gone, right? Now blood flows directly down into the heart the way it should. And so this is an SVC stenting, a very common condition that we deal with and something that we stent all the time, depending on the pathology of this. So what's really cool about this is that oftentimes immediately you see a big result, right? And so this is that same patient 10 minutes after the stenting, and you can see already, look how much better his face is, right? Look how much better his eyes are, that all that swelling is gone instantly because the blood now has a way and a pathway to go forward back into the heart. So that, it's a very simple, relatively simple and quick procedure that we can do, but it can really make a tremendous impact and obviously, really save a patient from being essentially dead because he can't breathe. This guy can't breathe at the end of the day with this.